Hello, I'm Barbara Messing from the Milton J. Dance Head and Neck Center, Johns Hopkins Head and Neck Surgery, and Johns Hopkins Voice Center located at the Greater Baltimore Medical Center in Baltimore, Maryland. I'm here to speak about alaryngeal speech options after laryngectomy. My disclosures are that I'm an employee of the Greater Baltimore Medical Center. I am an adjunct professor at Loyola University, and I receive financial compensation I received a small stipend from ASHA for this presentation. Non-financial disclosures: I'm a board member of the Milton Dance Endowment Board. I'm a board member and vice chair of the American Board of Swallowing and Swallowing Disorders. Clinicians working with head and neck cancer patients should educate and instruct patients and families before and after surgery to maximize functional outcomes and improve quality of life. Speech and language pathologists must be able to explain the basic alaryngeal speech options, and it's helpful for the patient to be able to share the information that they have heard so far about their upcoming surgery. Clinicians will instruct patients in both written form and, if possible, in video demonstrations performed by laryngectomies. Before the laryngectomy, the larynx connects to the pharynx, which connects to the trachea. The mucous membranes lining the larynx assist in warming and humidifying inhaled air. The sensitive larynx also triggers a cough reflex when touched by a foreign substance, such as food or liquid, to help prevent aspiration or material from entering the airway. A well-known function of the larynx, of course, is voice production. Exhaled air passes through the vocal folds, causing them to vibrate, producing sound. The sound is then shaped into speech by movements of the tongue, lips, and palate. After a laryngectomy, the voice box or larynx has been removed, requiring the patient to learn new methods for communicating and producing speech. Surgery to remove the larynx and vocal folds is called a laryngectomy. The connection between the pharynx and the trachea no longer exists after a laryngectomy. The trachea is positioned forward or anteriorly and sutured to the front of the neck, creating a new permanent opening for breathing, which is called a stoma. The loss of the vocal folds creates the need for alternative methods of communication. A person who has had his or her larynx removed is referred to as a laryngectomy. It's critical that there's an interdisciplinary team consisting of the patient, of course, and their family members, that's the primary members, the head and neck surgeon, and if the patient's going to have radiation or chemo after surgery, then the radiation oncologist and medical oncologist will have involvement in their treatment planning, as well as the dentist, and of course the rehab team consisting of the speech pathologist, oncology social worker, otolaryngology nurse specialist, and oncology dietitian. We first meet the patient who is planned to undergo a total laryngectomy through a pre-treatment or pre-operative interdisciplinary team meeting. The purpose of this meeting is to meet the patient and their family members, assess their knowledge of the upcoming surgery, the recovery process, and what to expect. The speech pathologist introduces the 3 methods of communication as indicated for that patient. This allows the patient to understand that after the laryngectomy, they will be able to communicate with their loved ones and others in their daily environment. Patients are followed through all stages of care. The team's involvement begins at this pre-operative or pre-treatment time period, and it continues post-discharge and often many years to come. This is a photo of the pre-treatment session. The pre-treatment session provides an excellent opportunity for learning to occur prior to the surgery, as well as ease some of the anxiety the patient and the family members are experiencing. Patient and family members report that this is extremely helpful to alleviate some of the fear of the unknown. Grower in 1991 stated that preoperative counseling reduces patients' anxiety and increases their compliance with the treatment program. This statement is often confirmed by our patients after this session. What are the goals of the pre-treatment session? The goals of this session are to introduce the clinical staff who will be working with the patient throughout treatment to ensure their rehabilitation needs are met, to allow the team to review and assess patients' current medical and psychosocial situations, and speech and swallowing function. It gives us a heads up on what to expect after the surgery. The team clarifies and reinforces information previously introduced by physicians. It provides an opportunity for the patient and family members to have their questions answered. We find the outcomes of this pre-treatment session are that patients and family members do feel better prepared for surgery. They're more aware of the anticipated rehabilitation needs following this very, very large surgery, extensive surgery. Patients and family members do report to our team that they're less anxious, and the session also enables our staff to assess patients' needs and plan appropriate treatment interventions. What is our role as speech pathologists in this session? We have rather a large role. We have a lot to educate the patient prior to a total laryngectomy. We want to review the anatomical changes related to voice and swallowing, discuss anticipated changes and how their function will change. We'll introduce the 3 methods of communication post-laryngectomy. We're going to talk about what's going to happen if the patient's going to have a TEP placed, and care and management of that TEP that will be required after the surgery. The electrolarynx is a communication option immediately post-surgery that's used and instructed, and it's a backup communication option for the patient. Esophageal speech is introduced as another communication option. Patients are provided with a video demonstration of the 3 options for communication. That's very helpful for them to actually see it demonstrated. So in further, I'm going to go into a little more detail on these 3 options. First, I'm going to talk about the electrolarynx, or the artificial larynx. Then I'm going to talk about the tracheal voice prosthesis and esophageal speech. This is a pictorial representation of the electrolarynx. And as you can see, the device is placed on the neck, causing a vibration through the muscles and the tissue, and that is going to produce sound. The electrolarynx is an external vibrating device that generates sound for speaking. It's essential for patients to be independent with the use of an electrolarynx, regardless of the anticipated means of communication that they may be using long-term. Training with an electrolarynx should be implemented by the speech pathologist within a day or 2 after surgery, and that'll provide them with an immediate way of communicating. That's really important to them. After surgery, while the patient is in the hospital recovering from surgery, the speech and language pathologist begins training on the electrolarynx, as well as other rehab needs related to the stoma, swallowing, and we introduce the heat moisture exchanger system at that time. But for the purpose of this talk, I'm focusing on communication options postoperatively. Instruction on the electrolarynx focuses on consonant and vowel combinations, word series, short functional phrases, and ultimately conversational speech. We instruct patients on 3 major areas. One is placement, secondly, on and off timing, and then compensatory strategies to improve speech intelligibility. For placement, an intraoral connector is used immediately postoperatively because the patient has had extensive surgery, and the vibration of the electrolarynx coming through the site is not recommended or preferred by the surgeon. So we use an intraoral connector so that the patient can use the electrolarynx safely. On-off timing is important. We want to make sure that the patient will be able to coordinate pressing of the electrolarynx and beginning to articulate at the same time. If there's a lag, then you'll either hear no speech at all, or there'll be a vibrating sound without any speech. So we want to work on that. We'll also work on compensatory strategies such as over-articulation and improving speech intelligibility through rate control. And those things are what we will focus on in treatment while they're in the hospital. Patients are encouraged to use the electrolarynx as their primary source of communication during this postoperative period. Typically, it involves 50% patient training and 50% listener training. Patients are encouraged to keep the electrolarynx as a backup form of communication once fluent with their TE speech. This is what we tell the patient about the electrolarynx. After your laryngectomy, you will no longer be able to produce voice with your vocal folds, since they will be removed during the surgery. The electrolarynx creates a vibration that's transmitted through the soft tissues of the neck, cheek, or mouth, and then shaped into speech by how they use their articulators. The lips, the tongue, and the same resonating areas are used: the mouth, the nose, and the throat. The advantages of the electrolarynx are that it's fairly easy to learn for most patients. It's an external vibrating source not limited by the pharyngoesophageal segment tonicity issues or other patient internal factors. The disadvantages are that all of these devices have a mechanical sound. It may be difficult for family, friends, or others in their daily environment to accept the sound and understand the patient. There is a learning curve that occurs. Patients have to also wear it or keep it nearby for communication, and sometimes it's misplaced somewhere in the home or in the hospital room. It's generally very monotone, and patients usually prefer esophageal or TE voice for more natural sound and to be closer to pre-laryngectomy communication. I'm going to now move on to tracheoesophageal voice. Here's an image of tracheoesophageal voice, and as you can see, the finger is up by the stoma placing on the HME filter. That's to occlude air from coming out of the stoma. Air then comes up from the lungs, goes through the prosthesis into the esophagus, and it flows up over the pharyngoesophageal segment. That causes the pharyngoesophageal segment to vibrate, producing a sound. So I'm going to talk a little bit more about what TE voicing or tracheoesophageal voicing is. It's a tract or opening or fistula that's surgically created from the trachea into the esophagus by the surgeon. It's usually the last part of the laryngectomy that happens. And this opening enables the passage of air from the trachea into the esophagus, and I'd like you to think about it like a party wall between two rooms. So after a laryngectomy, the communication between the lower airway and the upper airway is no longer there. And a puncture is created so that air can still flow from the lungs up through into the esophagus. This allows the individual who has had a laryngectomy to make or generate a sound in the area of their esophagus known as the pharyngoesophageal segment, or PE segment. With the TEP, there is daily care and management required. The TEP will need to be removed and replaced periodically, and sometimes there are barriers to successful TE voice. However, for the majority of patients, TE speech is relatively easy to learn and usually improves over time with instruction and daily use. Having the appropriate type and size prosthesis will have an impact on the success of TE voicing, as well as tissue integrity and the pharyngoesophageal segment tonicity issues. Now I'd like to play some examples of generally good TE voice production in a male and female speaker. As you listen, keep in mind that research done by Itty et al. In 2006 in an article in the Journal of Voice called Influence of Speaker Gender on Listener Judgments of Tracheoesophageal Speech found that listeners were not as accepting of female TE speakers and found that female speakers were not as natural or acceptable as compared to their male counterparts. They also often identified a female voice as a male voice, where of course obviously in the male speakers it's closer to their normal male fundamental frequency, so they identified males as male TE speakers. So I would now play the male. That was the male doing a sustained phonation. As you could have heard, it was a nice length. They were able to sustain that phonation for a nice period of time. And now I'm going to play the rainbow passage spoken by a male TE speaker with good tonicity.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow. The rainbow is the division of white light into many beautiful colors.
And now listen to the female.
When the sunlight strikes raindrops in the air, they act as a prism and form a rainbow.
And you can make your own judgments as to how that sounded, but in general, these are excellent TE speakers with good tonicity. So they're a good example and a good reference point to have for fluent and almost normal tone for a TE speaker. What is a TE prosthesis or a TEP? Well, it's designed for placement in the passage between the trachea and the esophagus. It is a one-way valve. It opens under positive pressure, and it maintains the puncture. It allows air to flow from the trachea to the esophagus for voice production. It prevents esophageal leaking of liquids and food into the trachea from the esophagus during swallowing or reflux events. Here is a photo of a voice prosthesis and the parts as noted. The esophagus and tracheal flanges allow for retention of the prosthesis in the fistula. The one-way valve allows airflow from the lungs through to the neopharynx for vibration of the pharyngoesophageal segment for voicing and prevents food and liquid from entering the airway. Patients will need instruction on using TE voice. Speech and language pathologists focus on using abdominal breath support, effective stomal occlusion, being instructed on the positioning of their finger to make sure there's not air escapage during voicing. And we also instruct them to use their non-dominant hand for voicing. We have to teach them coordinating breath and finger occlusion because that's not something that they normally had to do before their laryngectomy. And we also teach them to sustain phonation as a starting point, and then going into words and speech. So this speech and language pathologist will instruct patients to work on serial speech tasks, practice phrasing, and work in structured hierarchy of speech tasks and improving articulation. TE voice therapy or alaryngeal voice therapy also focuses on elimination of any negative behaviors that may be distracting to the listener. Facial expressions, altered articulation, body and head position changes. We want to make sure we instruct patients on a more natural approach. Eye contact and pragmatics are also very important. And then we want to pay attention to tonicity of the PE segment. Sometimes it may require medical intervention. Is there adequate tone, as you heard on those previous speakers? Is the patient hypertonic and real strained and tight, or hypotonic, more wet and gurgly? A patient's improvement can be assessed by how fluent they become. Patients are asked to count on a single breath. The more words on one inhalation-exhalation cycle, the more fluent they will be when they're speaking. Fluency depends on tonicity and pulmonary support as well. Fluent TE speech is generally being able to count up to 9 or greater on one sustained breath. As I said, there's care and management required for the TEP on a daily basis by the laryngectomy. One of the things we teach our patients is to flush and brush twice daily. It's kind of catchy and easy to remember. They use a flushing pipette, which is pictured on the right, and that is a little bit of saline is brought into the flushing pipette that is squirted into the stoma, into the prosthesis, and then that goes into the esophagus. The brush is also placed directly into the prosthesis, and that allows any mucus that may be clogging the prosthesis to be cleared on a regular basis. If the prosthesis is blocked by mucus or secretions, the patient will have more difficulty producing TE voice, so it's important. The ultimate goal for our patients is for them to achieve hands-free speech for those patients who have a tracheoesophageal voice prosthesis placed. This allows the patient to communicate with their loved ones on the job and in the community as close in presentation as their pre-laryngectomy method of communication, and that is hands-free. It's a device that eliminates the need for finger occlusion of the stoma during speaking. Again, when there is a tracheoesophageal voice prosthesis in place. Our role is to work on the setting and adjustment of it, speech training with the device, and optimal attachments, because the device itself doesn't attach to the stoma. We need something to attach it to, whether it's an interluminal device, such as a Larry tube, a Larry button, or a Barton Mayo button, or something that would be taped around the stoma, a housing, and then the HME, the hands-free hands-free valve will pop into that. I'm moving on now to our last form of communication after a laryngectomy, which is esophageal speech. And pictured here, you can see that air comes from the environment, is pulled in through the mouth, it goes into the throat, goes below the pharyngoesophageal segment, and then is quickly returned back up. It generates a sound as it passes over the pharyngoesophageal segment, and that sound is again shaped into words or speech as they move their articulators. Esophageal speech then is produced either by inhaled or injected air taken into the mouth that's brought down into the esophagus. The air must be returned quickly from the esophagus, and as the air is returned from the esophagus, a sound is generated for speaking. The pharyngoesophageal segment is the vibrating source for sound production. This is true for esophageal voice and tracheoesophageal voice. As I mentioned, esophageal speech is possible by several methods, or a combination of these methods. Esophageal speech is produced by injecting air or inhaling air into the upper esophagus to produce a belch-like sound that could be used for speech. Although this is an easy way to think of it, in actuality, a belch is very different, since it's air that comes from the stomach and it's more uncontrolled. With esophageal speech, air is quickly taken in by the patient from their mouth and trapped into the esophagus just below the pharyngoesophageal segment. The laryngectomy is instructed to quickly return the air coming back out as they produce a sustained vowel sound such as ah, And over time, the laryngectomy learns to produce a consonant and vowel combinations, and then on to words, sentences. Eventually, they're able to produce esophageal speech at the conversational level. With the inhalation method, the laryngectomy is taught to open their mouth and quickly take in air using a sniff, quick breath in. And the inhalation method, the injection method, the patient learns to use sounds such as putting their lips together quickly for a P sound or a B sound, or using their tongue to create a T or a D sound. And that injects air into their mouth, and then that air quickly travels into their esophagus and is returned quickly. An important thing to note about esophageal speech is that it should be taught by a speech and language pathologist. Patients may learn to produce a sound or two, but it's critical that they have a speech and language pathologist to guide them through this process of learning that will enable them to be more successful with this type of speech. The advantages are that it doesn't really require any supplies. It's the lowest option that the patient could have available to them. All one really needs is their own body and a lot of practice. The more natural sounding, it's much more natural sounding compared to electrolarynx, and the laryngectomy can learn to vary their pitch and loudness to a certain degree. The disadvantages are it can be very difficult to learn and certainly does require a lot of practice. You need to find a speech pathologist who can teach this method. Barriers such as stoma blasts, extraneous noises, inability to produce the sound due to pharyngoesophageal segment issues also come into play. If a TEP is in place, it may be difficult for the patient to transition between the two types of speech. There's a shorter number of words produced compared to TE voice and the electrolarynx, because with esophageal speech, you have a small reservoir of air that the patient is bringing in through their mouth, whereas with TE voice, they're bringing air up from their lungs, so it's essentially lung-powered. And your patient will be able to say more words on one breath with TE versus esophageal. I'm now going to talk a little bit about the postoperative care required for a total laryngectomy. During this period of hospitalization after the laryngectomy, it's recommended that a protocol be established for the patient to initiate the rehabilitation process. Postoperative care, postoperative laryngectomy, starts really post-op day 1. Augmentative communication evaluation with electrolarynx is initiated, and heat moisture exchanger system evaluation. There's ongoing training that happens every day while they're in the hospital. We work on the electrolarynx, the heat moisture exchanger system, stoma care, and remember, you have that patient as a captive audience that time, so you can see them every day, and that's a good learning experience. And also, you have a lot of communication partners for the patient to interact with. The medical staff, their patients and their families that are visiting, so it's a good time for them to get to learn how to use the electrolarynx. By post-op day 5 or 7, we do a modified barium swallow study. There are essentially two purposes for the modified barium swallow study, and one is to find out if they can initiate TE voice if they've had a primary TEP placed, and secondly, to see if they can start PO intake, eating by mouth. We're looking for a sinus tract or a fistula, so we want to see has the healing occurred and at the surgical site. We want to make sure there's no leaks, and if not, then the patient can start taking food by mouth, and they can also perhaps initiate TE speech. Timelines will vary depending on the patient's particular situation. For example, a salvage laryngectomy may have longer time periods or recovery periods due to their previous radiation. After the patient is discharged from the hospital, they're seen on an outpatient basis for therapy. Therapy focuses on ongoing electrolarynx training with the goal of proficiency in the electrolarynx and also initiation of TE voicing. Patients must learn to produce TE voice using finger occlusion first, and then the next steps are voicing with the heat moisture exchanger system or with the heat moisture exchanger filter in place. Patients must learn what to do in case of a TEP emergency. That's taught on the first visit. They will be instructed on what to do if they have trouble voicing. If the prosthesis is failing and liquids are leaking into their airway, they need to know to contact the center and come in for a change, or if it's on the weekends, to go to the the emergency room, or they need to know how to solve that problem by putting a plug in place until they can get to the center. If the prosthesis is partially or fully extruded, then they also need to know what the emergency procedures are for that. Patients do need to be educated so they're more prepared for these potential events. Care and cleaning of the prosthesis is also re-instructed. Time is spent on teaching placing the heat moisture exchanger system, which consists of a filter and an attachment method to allow the patient to attach the filter to their stoma. It's important for pulmonary health, but also to benefit the patients as they produce TE voice. Patients will need ongoing instruction in post-laryngectomy anatomy and physiology, alaryngeal speech, whatever method or methods the patient is using. Ongoing management of the heat moisture exchanger system, as I said, is important for pulmonary health. We need to also assess patients' swallow function as indicated and ensure patients have adequate nutrition and hydration because that healing is still occurring. Swallow function is monitored each session for diet level changes or weight changes. An important but often neglected rehab need of the patient is olfaction. Can they smell? As we know, patients who've had a laryngectomy do have a loss of the ability to smell. Speech and language pathologists should assess the patient's olfaction and provide them with instruction on the nasal airflow inducing maneuver. Speech and language pathologists also need to be prepared to discuss lifestyle changes with respect to bathing, recreation, avocational, and vocational activities. I can't think of a better way to teach someone about the 3 methods of communication after a laryngectomy other than watching laryngectomies use those 3 methods. And I am very, very thrilled to share this video of my patients who had the kindness to take their time to show you how they use the electrolarynx, TE voice, and I do have one patient, the first patient, who will demonstrate his use of esophageal speech.
Demonstrate how I can use all 3 of my voices. This is the electronic voice that I talk with. And this is my TEP puncture voice that I use. And then I can use my esophageal voice, whichever one I choose. I change back from my esophageal voice to my TEP puncture.
And which is your preferred?
I prefer to use the TEP puncture. Larynx that I'm using my prosthesis to talk to you right now. I have this thing here and it works very well. And I've been at it in it for 5 years now.
Do you use it in the community?
Yes, I use it in the community and I can talk to anybody. Everybody I talk to says I really talk well, so I'm only going with what they tell me.
And are you able to talk on the phone a little bit?
I can talk on the phone, and after a while, you get a little tired about it. It's very good.
And do people recognize your voice when you're talking to them?
Yes, they do.
All right, thank you.
You're welcome. My TE speech, I'm using my prosthesis to speak with. Now I have to use this here to talk, but I'm talking very good with this. But I'm really not too much with this, but I can. I know how to use it now.
So I've taken your prosthesis out and you're going to do a count for me on one breath. Let's see how high you can go. See how fluent you are.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30, 31, 32, 33, 34, 35.
That's very good. Can you do like a straight ah? That's good. So is it pretty easy to use your voice right now?
Yeah, real easy.
Okay, we're going to put the prosthesis in and go again, all right?
Okay.
Now I just changed your prosthesis. Let's hear how your voice is with the prosthesis in.
You want me to count? Or?
Yeah, take a nice deep breath and count as high as you can.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
That's pretty darn good. How does it feel?
Okay.
Yeah, your voice sounds good.
Yeah.
So you can use this in your community?
Oh, yeah, I've been talking about
At work?
at work and,
On the phone?
yeah, well, some people have a hard time understanding me on the phone.
Oh. How about when you talk to people you know on the phone, do they recognize your voice? People that know you, can they tell who you are before you say your name?
Yeah.
Yeah. Did that surprise you when you first had your laryngectomy that people could do that?
Yeah.
Yeah. So how's this TE voice working for you?
Real well.
Excellent. All right. Thank you.
You're welcome.
Sometimes you use esophageal speech for a word or two, huh?
Yes, I do. Sometimes it can even be a sentence.
Mm-hmm. And does that come in handy now and then?
Yes, it does.
Because you don't have your filter in, you don't have your hands-free valve, you just have the filter in.
Right.
So you can say a word, yes,
Yes.
or no,
No.
or a short sentence.
Short sentence.
Okay, very good. And then, or you can put your finger up and talk, right?
Right.
Either way.
But it's more clear.
Yeah, it's clearer that way. Okay, thank you.
You're welcome. You're welcome.
So now you're going to take your filter off and put your hands-free valve in so you can speak without putting your hands up. Show us how that works.
It works pretty good.
Nice.
Takes a lot of energy to project from the stomach up. It's the only difference.
Yeah, you have to use more air, you think?
Yes, I do.
Mm-hmm. And you use this a lot, don't you?
Yeah. Yes, I do.
Do you like it?
Yes, I do.
Okay. Well, you do very well with the free hands valve.
Yes.
Good job. Anything else you want to add?
Just that I'm grateful to be here today and be able to talk.
How nice. That's wonderful. Hi, good afternoon.
I'm Barbara.
And what are you using there?
The necrotic larynx.
And when did you first learn how to use this?
I used it when I was in the hospital for a week.
Ah, and did it help you right after your surgery?
Yes, it did.
And now if you take that down and you stop using it, put your hand down, show me how you talk normally now.
I used the prosthesis they've had inserted in my throat.
Mm-hmm.
And to me, I sound clear because I can hear myself better.
Yeah.
But this was, electronic larynx was exceptionally helpful in the hospital.
Okay, and now you use your TE voice everywhere, right?
Absolutely.
And I know you're retired, but you travel a lot.
Yes.
And where are you going next week?
Bermuda, and I'm doing classes with Barbara.
That's right, and you have just been speaking up a storm, huh?
I try like heck.
Yes, and how about your family members? Do they do a good job of understanding what
My
you're...
wife's got me setting up another medical bag for emergency right now
So you've got a medical bag for emergencies, yeah, that when you travel.
for each car.
Uh-huh, and for each car. Excellent. Well, your voice sounds really good.
I'm glad I'm trying.
So you use it out in the community when you're
Oh,
out?
absolutely. I cruise, so we're constantly talking to people.
Excellent. And how about when you are on the telephone? How is that?
I use the hard landline. It's better.
The landline's better?
Yes, but other than that, because I'm on satellite phone in my car.
Yeah.
So that's easier. I'm not talking to the cell phone itself.
Yeah. And do people recognize your voice when you're
My
calling?
sisters say they can't tell the difference.
Excellent, excellent. So this is working out pretty well for you?
I'm happy as can be.
All right, and you're getting ready for your cruise.
Oh, yeah.
Excellent.
But I'm still happy.
Anything else you want to say?
Know that everybody here at this hospital are fantastic. Everybody in this clinic, boy.
Thanks.
No problem. It's the
All right.
truth.
Have a good cruise.
I will. Thank you.
Thank you, sir. Post-laryngectomy voice restoration is really a journey filled with the opportunity for new learning and ongoing challenges. Thank you.